Hello and welcome to our Nursing Times bite-sized learning video series on heart failure. Over the course of 5 educational videos, we will be covering heart failure pathophysiology, heart failure causes, diagnosis, management and also related end-of-life care. Each video is presented by a nurse who is an expert in the field of heart failure. We hope you find this series an informative and useful tool to both further your knowledge, raise awareness and ultimately improve your care of heart failure patients.
Hello everyone, my name is Emil Elias. I work as an advanced nurse practitioner in cardiology and I'm the lead for the heart failure services at London North West University Healthcare NHS Trust. Today we are going to talk about heart failure management. So the goals of treatment of heart failure with reduced ejection fraction include prevention of disease progression, reduction in mortality, prevention of recurrent hospital admissions due to exacerbation of heart failure, and improvement in clinical status and functional capacity. So the focus of treatment is patient or person-centered care and improvement in quality of life. Let's talk about pharmacological treatments for patients with heart failure with a reduced ejection fraction. Pharmacotherapy is the cornerstone of treatment for HFrEF and should be implemented before considering device therapy and alongside non-pharmacological interventions. So there are 4 pillars of heart failure management when treating heart failure with reduced ejection fraction. And these drugs serve as the foundations of pharmacotherapy for patients with HFrEF. Management with these drugs has been shown to improve survival, reduce the risk of heart failure hospitalizations, and reduce symptoms in patients with HFrEF. Let us talk about each of these in detail. So, angiotensin converting enzyme inhibitors, or ACE inhibitors, they were the first class of drugs shown to reduce mortality and morbidity in patients with HFrEF. They've also been shown to improve symptoms. They are recommended in all patients unless contraindicated or not tolerated. They should be uptitrated to the maximum tolerated recommended doses. ACE inhibitor therapy should not be offered if there is a clinical suspicion of hemodynamically significant valve disease until the valve disease has been assessed by a specialist. So, angiotensin receptor blocker. An ARB licensed for heart failure should be considered as an alternative to an ACE inhibitor for people who have heart failure with reduced ejection fraction and intolerable side effects with ACE inhibitors. Angiotensin receptor neprilysin inhibitor. In the Paradigm HF trial, sacubitril valsartan was shown to be superior to enalapril in reducing hospitalizations for worsening heart failure, cardiovascular mortality, and all-cause mortality in patients with HFrEF. Sacubitril valsartan is an angiotensin receptor neprilysin inhibitor, including both a neprilysin inhibitor, which is sacubitril, and an ARB, which is valsartan. Sacubitril inhibits the breakdown of natriuretic peptides, resulting in varied effects including increased diuresis, natriuresis, and vasodilation. So, its Entresto, sacubitril valsartan, or Entresto, is recommended as an option for treating symptomatic chronic heart failure with reduced ejection fraction only in people with New York Heart Association or NYHA class 2 to 4 symptoms and with a left ventricular ejection fraction of 35% or less, and who are already taking a stable dose of ACE inhibitors or ARBs. It is recommended that an ACE inhibitor or ARB is replaced by Entresto in ambulatory patients with HFrEF who remain symptomatic despite optimal treatment. Patients being commenced on Entresto should have adequate blood pressure and an eGFR of 30. A washout period of at least 36 hours after ACE inhibitor therapy is required in order to minimize the risk of angioedema. So the first line of treatment for heart failure with reduced ejection fraction is with an ACE inhibitor or an ARB or an ARNI. It's one or the other. The second pillar is beta blockers. Beta blockers have been shown to reduce mortality and morbidity in patients with HFrEF, in addition to treatment with one of the above-mentioned drugs. They also improve symptoms. Beta blockers should be initiated in clinically stable euvolemic patients at a low dose and gradually uptitrated to the maximum tolerated dose. Mineralocorticoid receptor antagonists, or MRAs, constitute the third pillar of heart failure therapy. Spironolactone or eplerenone are recommended in addition to the first two pillars in all patients with HFrEF to reduce mortality and the risk of heart failure hospitalization. They also improve symptoms. Caution should be exercised when MRAs are used in patients with impaired renal function and in those with serum potassium concentrations of 5 millimoles per liter. SGLT2 inhibitor is an abbreviation for sodium glucose cotransporter 2 inhibitors. Dapagliflozin or empagliflozin are recommended in addition to optimal medical therapy with other three pillars for patients with HFrEF regardless of diabetes status. The diuretic or natriuretic properties of SGLT2 inhibitors may offer additional benefits in reducing congestion and may allow reduction in loop diuretic requirement. The other agents include ivabradine, which is recommended as an option for treating chronic heart failure for people with New York Heart Association class 2 to 4 stable chronic heart failure with systolic dysfunction and who are in sinus rhythm with a heart rate of 75 beats per minute or more and with a left ventricular ejection fraction of 35% or less. Another drug is digoxin, which is recommended for worsening of severe heart failure with reduced ejection fraction despite first-line treatment for heart failure. A combination of hydralazine and isosorbide dinitrate may be considered in symptomatic patients with HFrEF who cannot tolerate any of an ACE inhibitor, ARNI or ARB, or if they are contraindicated, to reduce mortality. Diuretics. Diuretics are recommended in patients with heart failure with signs and symptoms of congestion to alleviate heart failure symptoms, improve exercise capacity, and reduce heart failure hospitalizations. Loop diuretics such as furosemide or bumetanide are given to relieve signs of congestion and are up or down titrated according to the fluid status. Bumetanide has better bioavailability than furosemide. Intravenous furosemide may be required to relieve congestion in some patients based on the severity of their fluid overload. And thiazide diuretics or metolazone can be considered in addition to a loop diuretic when the clinical response to a loop in isolation is insufficient. The aim of diuretic therapy is to achieve and maintain euvolemia with the lowest diuretic dose. Loop diuretics produce a more intense and shorter diuresis than thiazides, although they act synergistically and the combination may be used to treat diuretic resistance. However, adverse effects are more likely and these combinations should only be used with care. Let's now talk about devices such as ICDs and CRTs. So ICD is implantable cardioverter defibrillator and CRT is cardiac resynchronization therapy. An ICD is recommended to reduce the risk of sudden death and all-cause mortality in patients with symptomatic heart failure and a left ventricular ejection fraction of less than 35% despite more than 3 months of optimal medical therapy, provided they are expected to survive substantially longer than 1 year with good functional status. ICD implantation is not recommended within 40 days of a myocardial infarction, as implantation at this time does not improve prognosis. ICD therapy is not recommended in patients with NYHA class 4 with severe symptoms refractory to pharmacological therapy unless they are candidates for CRT, a ventricular assistive device, or cardiac transplantation. CRT or cardiac resynchronization therapy. Patients with HFrEF and a QRS duration of more than 130 milliseconds can be considered for CRT with a defibrillator or CRT-D rather than ICD. Patients with an LVEF of 35% who have received a conventional pacemaker or an ICD and subsequently develop worsening heart failure despite optimal medical therapy and who have a significant proportion of right ventricular pacing should be considered for an upgrade to CRT. In appropriately selected individuals, CRT reduces morbidity and mortality. CRT also improves cardiac function and enhances quality of life. Let's now talk about heart failure with mildly reduced ejection fraction. As in other forms of heart failure, diuretics should be used to control congestion. No substantial prospective randomized controlled trial has been performed exclusively in patients with heart failure with mildly reduced ejection fraction. However, some studies have demonstrated that patients with heart failure with mildly reduced ejection fraction would possibly gain more benefits from some targeted therapies with HFrEF than those with HFpEF. So HFpEF, or heart failure with preserved ejection fraction, diuretics are used to relieve congestion. Until recently, no treatment had been shown to convincingly reduce mortality and morbidity in patients with HFpEF. The treatment options for HFpEF are being revised with the publication of 2 large clinical trials, the Emperor Preserved and Deliver, that studied the effectiveness of SGLT2 inhibitors, empagliflozin and dapagliflozin respectively, in patients with heart failure with mildly reduced ejection fraction and preserved ejection fraction. In fact, 2/3 of the patients in both trials had an LVEF of more than 50%. The primary endpoint included cardiovascular death and heart failure hospitalization. Early diagnosis and early initiation of an SGLT2 inhibitor can reduce heart failure hospitalization and improve quality of life. And it's important to identify and treat the underlying risk factors, etiology, and coexisting comorbidities in heart failure with preserved ejection fraction. Arterial hypertension, atrial fibrillation, coronary artery disease, obesity or metabolic syndrome. Treat all these conditions according to respective guidelines. Patient education, self-care, and lifestyle advice. Adequate patient self-care is essential in the effective management of heart failure and allows patients to understand what's beneficial and to agree to self-monitoring and management plans. Heart failure patients who report more effective self-care have a better quality of life, lower readmission rates, and reduced mortality. Adequate patient self-care is essential in the effective management of heart failure and allows patients to understand what's beneficial and to agree to self-monitoring and management plans. Exercise rehabilitation. There is consistent evidence that physical conditioning by exercise training improves exercise tolerance and health-related quality of life in patients with heart failure. Clinical trials and meta-analysis in people with heart failure with reduced ejection fraction show that exercise rehabilitation improves exercise capacity and quality of life. Several meta-analyses also show that it reduces all-cause and heart failure hospitalizations. Let's talk about general follow-up. An ECG should be done annually to detect QRS prolongation, as such patients may become candidates for CRT. Furthermore, it may identify conduction disturbances and atrial fibrillation. Serial echocardiography is generally not necessary, although an echocardiogram should be repeated if there has been a deterioration in clinical status. An echocardiogram is also advised 3 to 6 months after optimization of standard therapies for heart failure with reduced ejection fraction to determine the need for addition of newer pharmacological agents and implanted devices. Advanced heart failure. Many patients with heart failure progress into a phase of advanced heart failure characterized by persistent symptoms despite maximal therapy. the prevalence of advanced heart failure is increasing due to the growing number of patients with heart failure, aging of the population, and better treatment and survival of heart failure. In patients with advanced heart failure, pharmacological therapy and short-term MCS or mechanical circulatory support may be needed until the implantation of long-term MCS or heart transplantation becomes available. Inotropes may improve hemodynamic parameters, reducing congestion, augmenting cardiac output, and aiding peripheral perfusion. Although not proven, this may help to prevent worsening end-organ function. In patients who fail to respond to diuretic-based strategies, renal replacement therapies should be considered. Ultrafiltration is one of the most common approaches. Mechanical circulatory support, or MCS, can improve survival and symptoms of patients with advanced heart failure. Short-term MCS devices are indicated to reverse critical end-organ hyperperfusion and hypoxia in setting of cardiogenic shock. They can be used for a short, limited period of time, from a few days up to several weeks. The aim is to support the central nervous system and organ perfusion to reverse acidosis and multi-organ failure until the patient's outcome becomes clearer, be that of cardiac recovery, transition to durable MCS or heart transplantation, or in some cases towards a more palliative approach. Long-term MCS is indicated in selected patients when medical therapy is insufficient or when short-term MCS has not led to cardiac recovery or clinical improvement to prolong life and improve quality of life, or to keep the patient alive until transplantation or bridge to transplantation, or to reverse contraindications to heart transplantation or bridge to candidacy or BTC as a destination therapy. Heart transplantation. Heart transplantation remains the gold standard for the treatment of advanced heart failure in the absence of contraindications. Post-transplant 1-year survival is around 90%, with a median survival of 12.5 years. Transplantation significantly improves quality of life and functional status. Organ donor shortage remains the main limitation to heart transplantation. Symptom control and end-of-life care. While the disease trajectory of each patient with heart failure is unique, there is a generalizable pattern of gradual decline, punctuated by episodes of acute deterioration, leading either to sudden death or death due to progressive heart failure. Communication about the disease trajectory and anticipatory planning should start when a patient is diagnosed with advanced heart failure. So, in conclusion, prognosis can be difficult to estimate for a person because heart failure often has an unpredictable trajectory with stable periods interrupted by episodic acute destabilization. Mortality. About 50% of people with heart failure die within 5 years of diagnosis. About 40% of people admitted to hospital with heart failure die or are readmitted within 1 year. Many patients with heart failure progress into a phase of advanced heart failure characterized by persistent symptoms despite maximal therapy. Proactive decisions and advanced planning with regard to palliative and end-of-life care discussions should be documented, regularly reviewed, and routinely communicated to all those involved in the patient's care. New developments in management provide hope. But we as nurses have a significant role to play in the management of heart failure patients. We should do everything we can for our patients to have a better quality of life, since patients are at the heart of everything we do. Thank you.